Alright, good morning everybody. Welcome to day 2 of this year's summer school. As you can probably tell, I'm not Michael O'Flaherty. Michael unfortunately had to go to Brussels at short notice, so unfortunately he's not able to be with us today, so you're stuck with me as a chair up until this afternoon. I just have a few announcements to make before I introduce our first speaker this morning. So the first thing I want to say is that tonight is our movie night. So the movie will be showing in here at 7:30, so that gives you time after today's session is over to go get something to eat and come back for the film. But before the movie, we're having a special event, which is that Jonathan and Fionn Angus, Fionn is the young man who produced a lot of the art that you've seen in the foyer, so they're just going to come at about 7 p.m. to talk for a few minutes about their exhibition. So really you should be here at 7 p.m. so you can hear Jonathan and Fionn's talk, and then the movie will start showing at 7:30. A few other procedural announcements. So as I mentioned yesterday, the mood problem and all of the materials from this week are being loaded up on Dropbox every day, along with the transcripts from the cart, so that you can see the transcript of each day. I know that Dropbox is not accessible to everybody, so if people have an accessibility request and need materials emailed to them, instead of writing down your names, because we are having trouble deciphering some people's writing, if you could send an email to the Disability Summer School email, we'll make sure to get the materials to you in a format that's accessible. And the other thing I want to do before we start is to see how many people are intending to go to each of the breakout sessions today so we can decide what rooms to put you in. So if we could have a show of hands, who's intending to go to the Right to Health session? Okay, and the gender equality session? Okay, much more people for gender equality. Okay, so that needs a bigger room. That's great, thanks very much. So, apart from the change in the chair today, we just have one more change in the programme that I want to announce to you. Hans Zomer from DOCUS, who was to be speaking on Thursday, is now joining us today instead, and he's going to chair the panel after lunch on inclusive development policy and practice. So, now that that's all the housekeeping out of the way, I'm going to introduce our first speaker this morning, which is Dr. Maria Kett, whose particular area of specialism is disability-related issues in situations of disaster and conflict. And she's worked in many countries, including Bosnia, Azerbaijan, Sierra Leone, Sudan, Sri Lanka, Pakistan, and Liberia. So she has a wealth of experience in this field, and her research interests include social exclusion, psychosocial impacts of conflict, effects of displacement, measures to alleviate poverty, and broader issues around development and human rights. Welcome, Maria.
Oh, thank you. Okay, so, well, good morning, everybody, and thank you for inviting me here. I feel like I'm in illustrious company, and I'm only slightly relieved, and I shouldn't really say this, that Michael O'Flaherty is not here, given when I read his biography, and he's been to almost all the countries I have and set most of the UN missions up, so he'd probably have a lot to say about a lot of the issues that I'm going to talk about, so probably just as well he's not here. I sort of always feel like when I come to talk about things, people think this is going to be a really cheerful subject, and it is, there's not a lot of, I want to try and be positive about this area. I know it sounds, risk and humanitarian emergencies, there's a lot of doom and gloom about it, obviously, but I also want to say there are a lot of positive things that can come out of these situations as well, which hopefully by the end of this session we'll see ourselves. I also want to talk a little bit about me, just so you sort of can situate where I'm coming from in this, and I should confess from the outset that I'm not a lawyer. I am an anthropologist by training, but a lot of the work we do at our centre, the Leonard Cheshire Disability and Inclusive Development Centre, which is a research centre based at University College London, is very applied research. We do we link what we do very closely to programmes and policy. So a lot of what I'm speaking about here is trying to sort of really speak to what I think the overarching theme of this session today is, really trying to bring the disability inclusive development into practice. What does this look like, particularly in the area of conflict and emergencies? A lot of what I'm going to talk about is based on a briefing paper that I co-authored at the end of last year with somebody called Pauline Oosterhoff, who's based at the Institute for Development Studies in Sussex. And that was the DFID-funded rapid response briefing paper, and I'll give you the link to that at the end here. And that briefing paper was sort of initiated by the Ebola crisis in West Africa. Some of you are here from those parts today. And it was really trying to sort of look at how were disabled people being included in the Ebola response. And I think it was also an opportunity for me to reflect on 10 years, really, more than 10 years of working in this field and in this sector. And there's been a huge amount of work going on in this. You know, we talk about the work that's been going on in Syria, one of the world's biggest refugee situations now. 6 million people displaced by the conflict there. But we think back over the work that's happened and the disasters that have happened from the tsunami, the Indian Ocean tsunami in 2005, Hurricane Katrina, the Haiti earthquake, earthquakes in Pakistan, Nepal. There's been a lot of disasters going on in the last decade. And it's really a point as well to try and reflect, a bit like Rosemary said yesterday, to reflect where we've got to within the sort of disability sector vis-a-vis conflict and emergencies. I also should say that I've had a lot of technical experience working as an advisor. Some of you might know what the SPHERE standards are. The SPHERE standards are the humanitarian guidelines used by practitioners in emergency situations. And so in the most recent revision of the SPHERE standards was in 2010, and I was the global focal point for disability in that revision process. So I led a global working group advising on how to include disability in the SPHERE standards, and I'll talk a bit more about that later on as we go, so you can see how that fits. I'm going to talk quite broadly. I wasn't quite sure how to pitch this, and I've already confessed to you I'm not a lawyer, so it was quite... So I don't know how much people know, really. So what I thought I might do is give you an idea of the context, because in the humanitarian sector, quite important to understand the context that we're working in. And that's been a gap, I think, for a lot of the disability, particularly for a lot of the disabled people's organisations. It's a massive sector, quite complex, and a lot of different components. So I want to talk about the context and the impacts of humanitarian crisis and the responses to humanitarian crisis. And you'll note so far I've been quite careful about using the term humanitarian crisis, and I think when we come to the definitions, you'll see that Article 11 makes very clear the differentiation between conflict and natural disasters. You can use the term, I'm doing anthropology diacritics, we do them all the time. It's rare to see it entirely naturally, but I think this is really important because there are two different ways to respond. Conflict has a very specific set of legal requirements. It's guided by international humanitarian law as well as international human rights law, whereas disaster response isn't. So I think it's clear in some ways to see that they often and have been two separate strands of work. And that's quite important because so it means Article 11 is a big cover-all, but it actually is talking about two quite different and distinct routes that can be gone through. I want to then talk a little bit about where disability has and hasn't been included in humanitarian work. And this has been an interesting trajectory, really. As I said to you, when I first started work in this sector, I went to Sri Lanka after the Indian Ocean tsunami. I went in January 2006, and without naming any organisational names, I can quite safely say that not many doors were open to discussions around disability at that point. It really wasn't something that the humanitarian community had taken on board. That's certainly not the case now. We wouldn't have the discussions now that we were trying to have, or let me rephrase that. We would have the discussions now that we couldn't, we had real difficulty having in 2006. So I think there has been a huge amount of progress. And in some ways, I think the humanitarian sector has been more advanced in that, and we'll come back to that, and that might be something to pick up in discussions and debates. So that sort of leads on to the achievements. But of course, and it wouldn't be a discussion about disability if we didn't say there were still some gaps and challenges, would it? So that I have to talk about those. I think it's really important to sort of say as well that we know, and we've talked about this yesterday, of the estimate billion people with disabilities that live in the world, we still, and again, this is a bit debated, but we say approximately 80% live in poorer countries, lower income countries, with all the implications that that has. Of course, it means that they are more vulnerable to disasters. It doesn't necessarily mean that those countries are more likely to experience disasters and conflict, But what it does mean is that the responses to them and the mitigation and the preparation is very different. Things like insurance, emergency response, political will are very different in the lower income countries, partly because of capacity, partly because of donors, and all the other reasons that I'll come on to. So what of course it means is poorer people are more likely to be affected. People with disabilities are often amongst the poorest of the poor. So we know that people with disabilities have been historically some of the most badly affected by disasters, but haven't necessarily been the most included. So I'm going to talk a little bit about that today. So we've got a lot to get through. So just to give you a bit of a, this is kind of what I teach my students, so this is to give you a bit of a sort of background of what the kinds of situations we're talking about. And remember, as I said, this can be seen in two different strands of work. So the sorts of geophysical hazards, the earthquakes, the flooding, volcanoes, landslides, we're quite careful, I think, in the disasters community. We call them natural disasters, but I think that people who work in that sector would say the responses are anything but natural. And as I've said, those, if you think about an earthquake impact in Japan, where they have strong buildings, good response systems, good early warning systems, compared to an earthquake in somewhere like Iran, the responses and the impacts are very, very different. Other things that necessitate humanitarian interventions are things like large-scale industrial accidents, as well as the more obvious situations like population displacement. And broadly, failure of states to protect their citizens. And this issue of protection is something we'll come back to, because in the humanitarian sector, this protection is one of the key components of good humanitarian response. Any situation of resource scarcity, particularly famines, but any resource scarcity can also necessitate humanitarian intervention. And epidemics, and this was always the one that kind of, was the sort of SARS, the flu that hasn't yet come. But of course, we've seen more recently in the last sort of year, the Ebola epidemic, and how quickly and how, it really did impact on communities in West Africa. And I think what the Ebola epidemic really demonstrated was how people with disabilities are still quite easily overlooked. There was a lot of exclusion of people with disabilities in the public health campaigns, particularly in the West Africa countries. People weren't getting those messages in the required accessible formats. And of course, people who needed additional support or carers in a community where you cannot touch somebody, this has a massive impact on people's lives. So again, despite all of the work that's been done, the Ebola response did flag up some of the ongoing challenges. However, I should say, and perhaps my colleagues from West Africa will come in here, there was some very good work done and really some good lessons to be learnt about mainstreaming disability across the Ebola response. So they're some of they're not the only ones, but they're some of the key and main ones. And I think it's also important to consider some of the sort of features of humanitarian crisis. We often think of humanitarian emergencies as being just that, an emergency. It's a sudden, big, all singing, all dancing. It engenders a massive response. The UN machine starts rolling, and it is a huge and big business. And that's a given, really. But not all disasters are that rapid. We often have slow onset. We have famines, or, you start to see things like failures of states to protect their citizens. You can start to see these things happening a long time before they become a crisis. Of course, the question is, when does that response start to happen? When does the humanitarian machinery start to click into place? And famine is perhaps a good example of that. There are many famine warning systems now around. But of course, and this is a very complicated situation, it has to get to a certain level before it triggers a response within the UN system. It then triggers a funding mechanism, because the response needs to be funded. Then you start to get the teams together to go to the field. So these can be very slow onset. What is key is, even if it's a sudden onset disaster, the sort of recovery is never that quick. It's very protracted, and some can be incredibly protracted. We used to think in terms of a year, 2 years, even the best will in the world. I don't know if anyone's been to Aquila in Italy. Even how many years after the big earthquake in Italy, things are still, not back to sort of normal. So we can talk 5, 10 years. And this is something, I think Rosemary said it yesterday, in the humanitarian sector, we want things to happen quickly. We want quick quick wins, but this isn't a quick win, and it never is going to be a quick win. It's a long-term process. And of course, and I know there are a lot of donors in the audience, but all of these are affected by geopolitical considerations. This is a given. I think one of the questions yesterday was about Francophone and Anglophone countries. Similarly, you know, where the disasters happen, what the geopolitical interests are of neighbouring countries, of regional states, and the international community really do affect the response to those humanitarian crises. So that's something that has to be taken into consideration. Of course, the underlying poverty or income level of that country and the donor attention also affect the impacts of the humanitarian crisis. And I've already said that there are different, disasters necessarily have a different response to conflict, but I want to talk just a little bit more about conflict. I think the impacts can be similar, but as I said, importantly, they engender a different response. Conflict in particular has a set of legal requirements that may come into play, which don't necessarily happen in a disaster situation. We can talk about some of these impacts. They can be social, they can be physical. I'm going to just go through the social and then I'll talk a little bit about the physical impacts. We know that in any emergency, actually, that things like social structures and networks are destroyed. And this is hugely important for communities that have limited capacity and resources. If a conflict happens, countries may already be poor, but an impact of a disaster, a violent conflict, a humanitarian emergency is certainly not going to make things better. It may, in fact, may make poverty much worse. Often that also necessitates social exclusion. We can guarantee there'll be loss of infrastructure. It's very interesting. The Ebola crisis in Sierra Leone, I think we were talking about this yesterday with our colleague, one of the things it really has highlighted in the last decades, the enormous amount of donor funding that has gone into that country, but how weak the health system was, how limited, not just the health system, water points in schools, the lack of running water, the lack of sanitation. It really has sort of highlighted that there was a real lack of infrastructure still, but we know that they can be destroyed in conflict and not necessarily built back at a rate or speed. Of course, in any kind of humanitarian emergency, but particularly conflicts, people will flee. That's a given. You or I would do the same if we could. So the first people often to go are people who have transferable skills or skills that can be utilised elsewhere. And that often means the teachers, the doctors, the nurses, the people who have skills that can be utilised elsewhere. So that means that the remaining behind, the country and the people remaining behind, lose those essential skills. An important factor is the idea of this lack of security, and that doesn't necessarily just mean a physical lack of security. It can mean the fear. You know, part of particularly tactics of warfare can be a deliberate tactic to make people afraid. There are many situations around the world, Darfur might be a good example, where it was actually the fear of being displaced which was as significant as the actual fact of being displaced. So the idea about being insecure, living in a very precarious and insecure environment. And of course, and I'm going to talk about this much more, this idea of increased civilian injuries and deaths. Traditionally, in the sort of post-Second World War, we used to talk about sort of for every one civilian, 10 military personnel would be killed or injured. They say now that that's reversed. In fact, we don't even try to talk about this anymore because actually trying to differentiate between who's a civilian, who's a combatant now is much, much, much less clearer. And particularly in post-conflict countries, conflict and post-conflict countries, we see large amounts of small arms and light weapons remain in circulation, causing injuries and deaths that would not necessarily have happened if they weren't in circulation. If you remember yesterday, one of the points on the questions that Rosemary asked was about the demobilisation, disarmament and reintegration. The disarmament bit is very important. You want to take the weapons out of circulation. You want them not to be in the countries. But that isn't always the case. Cambodia, for many, many years after, and I think places El Salvador is another case, huge amounts of small arms and light weapons still in circulation. And of course, what this all means is there becomes a kind of normalisation, acceptance of violence as the way things are and the way things will always be. And that has a long-term impact on people's health and well-being. And it's tempting, isn't it? When we talk about disability, we often talk about trying to not medicalise disability. So I'm not trying to talk about this as a sort of a medical issue. But what I want to do is, when we think about the impacts of conflict or disasters, we often do think about the health impacts. And these are both direct and indirect results of conflict. And I think it's important just to think about these, because what I want to talk about is link these to what the implications of these all are. So we know that there's obviously an increased mortality, and that can be a direct result, whether it's from weapons attacks, sexual or gender-based violence. But there's also the indirect attacks, things like anxiety, mental distress, malnutrition, chronic diseases. These really all can increase morbidity. So you have to remember, mortality means death, morbidity means long-term health effects. And related to this, and perhaps something that has been less thought about, is the links to increased disabling consequences. That could be things like injuries as a result of the conflict, landmines, one of the most obvious, but also the perhaps less obvious ones, and I'm going to come back to this, impairments that result from a lack of vaccination campaigns, public health campaigns during conflict, things like polio vaccines can't be done. And where they are trying to be done, so more recently you think about examples in Pakistan, some of the impacts of that have been very significant. But of course, it also increases in things like mental health conditions, substance abuse, post-traumatic stress disorder, and massive impact on people's sense of isolation. So you see that conflict has huge impacts on people's health and well-being. This is a very complicated diagram, which is all it's doing is trying to show you the sort of background factors that can increase morbidity and mortality in any crisis situation. So that could be things like poverty, inequality, economic stagnation, arms proliferation, seismic risk, which is risk of earthquakes, political instability, ethnic rivalry, competition for resources, environmental vulnerability. These are all sort of factors that underlie what the impact of the conflict or the disaster is going to be on any country or population. We know that if you live in poverty, if you have political instability, the impact is likely to be greater. And then there are, of course, a number of intermediate risk factors, things like the actual situation of armed conflict, psychological and physical distress, food insecurity, abusive relationships, access to health services, breakdown of government services, displacement, disasters, all of these factors. And then, of course, you have things like, once you get the conflict or the disaster, overcrowding, inadequate shelter, lack of nutrition, inadequate vaccinations, poor water and sanitation, blah, blah, blah. So what you see is the conditions, the background conditions can really have a massive impact on the outcome. But I think it's also important to say that some of these have been changing over the years. Traditionally, we used to think of, when you think of the sort of large-scale conflicts, let's say post the Rwandan crisis in the 1990s, huge population displacements over the border into what was then Zaire, is now the Democratic Republic of Congo. You know, the camps, and maybe we're starting to see, we had got better at doing this as a result of all the work that was done in post-Rwanda. You know, things like the diseases of overcrowding, particularly things like cholera control, had got much, much better. There's some idea now that it's getting a bit worse again in places like Syria, partly because of just the sheer volume and sheer numbers of people. But we're, you know, technically the humanitarian sector has got much better at the sort of diseases of overcrowding, for want of a better word. However, we're less good, and there are still significant numbers of particularly children, but not just children, dying of neonatal conditions, pneumonia, diarrhoea, endemic diarrhoea. And they persist, particularly in some regions of sub-Saharan Africa and South Asia. But interestingly, and this has become a real problem for the humanitarian community, the sort of chronic diseases, the diabetes, the cancers, the heart diseases, are becoming more prominent in post-conflict and post-disaster situations, partly because of global demographics. We're living longer, we're living with different health conditions, and that's being reflected in the populations that are being displaced, for example. And this, you know, Syria was a higher middle-income country. It had good health systems. You know, there was a lot of people there who had access to cancer treatment, who had access to diabetes care. When they're displaced, all of those accesses are lost. Well, what are the implications of that, and what are the the knock-on effects for things like long-term chronic health conditions? They may then turn into disabling consequences and impairments that have significant disabling consequences. And this is really important, and why I'm sort of leading up to this, because it does have a lot of implication for the kind of interventions that the humanitarian community are doing and what's being funded. big debates now in UNHCR about how much money can be spent per person on treating health conditions. And this does have implications, I think, in terms of human rights and some of the work that you might be thinking about doing in the future. These are big debates that, lots of moral wrangling about it. Paul Spiegel, who was is the person that this work is citing, he's head of health at UNHCR and has done, a lot of work with a lot of people to really try and, think through these quite big issues because they do have implications for people. But interestingly, it also slightly shifts what we might traditionally see as the patterns of conflict-related disabilities and impairments. I'm not saying we're not going to see the mine injuries, the gunshot wound, the bomb blast injuries, the hearing loss because of bombs, but we're also going to see different types of conditions as well. And I think this is something that the humanitarian community is really very aware of. I'm less sure the disability community has made those connections yet. This is my accidentally, I'm going to put it all up at one go. So in sum, you can see that war or any kind of humanitarian emergency has a wide range of very complex health effects. Those health effects can be both directly on people's health and on the healthcare system, as well as indirectly on the broader community. Those effects are changing over time, and that has importance for the terms when we're thinking about how we plan our humanitarian interventions in the future. Traditionally, the humanitarian community, and this is very important, we count mortality rates. Does anyone know why that's important? Why do we need to why do we count mortality rates? What do we need to know? Go on, have a guess. So if you don't know how many people, so basically the number of people dying engenders a different response. It's as brutal as that. When it gets to a certain level of people dying, that's when the humanitarian response comes into being. So you have to know it to know when it is a humanitarian emergency. But more recently now, people are starting to include things like morbidity and disability rates in those numbers, because actually people aren't necessarily dying at the same rates. They aren't dying of the traditional diseases of conflict or health impacts of conflict. As I say, they may be surviving, but surviving with significant health impacts. Another issue, and something that we'll come back to because this is particularly important when we're talking about Article 11, is the issue about who is a civilian and who is a combatant. Again, as I've said, these boundaries are blurring, but it does engender a very political debate. And finally, and again, this is a point we're going to come back to, as you have probably seen from the discussion that Rosemary was talking about yesterday, actually measuring some of these things is very different. We all talk about getting data, getting better information, but how do you measure some of these things? It's pretty difficult doing mortality and morbidity rates in a conflict zone. It's quite hard to go out and do sentinel. If you think about the traditional methods of doing, counting people, going out to the field, well, if there's an active conflict, it's quite difficult to do that. But more importantly, some of the other measures are less easy to define. Things like mental health issues, social health, these are quite difficult issues to define. So, as you see, it's really becoming quite a complex issue. So where does this leave us all? There are other factors that also complicate this, and I want to sort of talk about this because I think, again, this talks to the Article 11. If you think about Article 11, it's one of many, more than 30 articles in the Convention, which is in itself a human rights convention. And we had a lot of discussion yesterday and maybe debate that there are no new articles. It doesn't say anything new, it just says it's specifically for persons with disabilities. So this convention has to be seen in the sort of tension, I think, between the humanitarian world and the development world. And there is a tension between the two because it engenders a different response, different funding mechanisms and different focuses. And I think that's something that the humanitarian community have already been grappling with for some time now. There is obviously an immediate phase, an emergency, immediate response phase. You can call it the early phase, the immediate, or whatever. In fact, and in reality, unless there's already a system in place, the most likely people to be there in the immediate phase are local communities themselves. Much, much less likely to be a big international community response. And then we talk about the post-emergency phase or the intermediate phase, and then we move into the long-term phase, which may or may not include resettlement of communities back home. And increasingly, this has been a lot of debate about how relevant these divisions are. Is this an artificial division between the sort of emergency phase and the long-term development phase? But as I said in the beginning, it does make a difference because it has legal implications. It also has financial implications. And again, the issues of where persons with disabilities fit into this and how the sort of convention can speak to this bridging the humanitarian and the development gap is something that probably wants further discussion. And I think something when Janet Lord, if she ever gets here, she's written about this, so I think it's something you might want to pick up with her. I'm going to touch on this because it came up a little bit yesterday, so it's something that's probably useful to have a conversation about, just because I think it helps us to understand some of the issues that we might be talking about in terms of the convention. When and if we ever get to the post-conflict recovery phase, in Sierra Leone, I was there last week, and now we're in the Ebola recovery phase. So that's the sort of discussion. We're now in, and that means there's a lot of funding about for recovery processes, getting people back to school, getting hospitals open, getting systems back up. So the recovery process is always a huge, and this sounds callous, but bear with me, it's an opportunity. And I'll explain why, and I'll come back to that point. And the other thing to say about some of these points I'm going to make is some of them have legal implications, and again, that's where the convention comes into play. So there are a huge raft of processes that happen in any post-emergency phase. Yesterday we spoke about the DDR process, the disarmament, demobilisation and reintegration process, and some of the challenges and opportunities that might have vis-à-vis persons with disabilities. Lots of debate here around combatants, ex-combatants with disabilities. The return, resettlement, reintegration and resettlement process, these are all very international community. These are very much the sort of language that the international community use. Again, these have specific implications for persons with disabilities. A lot of these are requirements that haven't necessarily been inclusive of persons with disabilities. Infrastructure reconstruction. Here's a brilliant opportunity to get things built back in an accessible and universally designed way. Social reconstruction, again, opportunities to make things more inclusive. And if you think about inclusion in a post-conflict environment, and this is one of the debates we often have in the inclusive education, and I know, I don't think she's here, Rosemary, but one of the discussions, actually, if you look at the literal meaning of inclusive education, it is much more than just children with disabilities. It encompasses a variety, a whole raft of issues. So in a post-conflict environment, this is the language that many people want to understand and have a discussion about. It might mean, in the Northern Ireland context, it can mean bringing together the Protestant and Catholic communities. In different conflicts, it means bringing together and reconciling fractured communities. So there's opportunities in this social reconstruction to bring in things like inclusive education, maybe to be more than just disability inclusive, but also to include people with disabilities. Things like land redistribution. Again, in many countries, and I know Janet Lord has written about this with Michael Stein has written about this with Nora Groth. People don't necessarily have access to land rights. Women often don't have access to land rights, but certainly people with disabilities may not have the same equitable access to land distribution and rights. Food security, addressing inequalities, a massive focus post-conflict is this issue of restoring rights. So here's a brilliant opportunity to bring the whole. There are only 9 human rights conventions. That's not that many. It's a huge opportunity to bring the issues of disability to the table and have those discussions. Reforming the judiciary system, again, we spoke about that yesterday. Democratic election processes. I think what I'm trying to show you here is that actually this is much bigger than, of course, just including people with disabilities, but it's an opportunity. And I think some of the, I don't know if it's mistakes, but some of the challenges we've had in the disability sector is we are over here and everyone else is over there, and rare do the two meet. The humanitarian sector certainly 10 years ago was probably one of the least disability inclusive sectors there was. I think it's probably now it's one of the better ones now in some ways, and you can challenge me about that after, but we need to see that disability and it's a horrible term, this mainstream, cross-cutting, but it really should be, if we're talking about things like democratic election processes, that means democracy for everybody, for every citizen. So how do you make those democratic processes inclusive? Things like mental health and psychosocial support, massive amounts of money goes into mental health and psychosocial support post-conflict. But do people think about that in the disability issue? Oftentimes, even in the humanitarian sector, disabilities over there, the psychosocial groups over there, they don't necessarily even speak to each other. So it really is important to try and think about these. And this whole issue of reconciliation and justice. And I want to come back to this because some of these issues are very important for people with disabilities. This whole issue of transitional justice. Yesterday, Rosemary talked a little bit about some of these things. Post-conflict in particular, a real goal, as I said, is to try and heal societies, to bring societies back together, to heal the divisions that have come about of gross and massive human rights violations. And that is often done through this idea of transitional justice. Transitional justice is a relatively recent term, probably post the Second World War and post the sort of Eichmann trials. And it really does try to bring together groups to try and truth-telling is inverted commas because truth is always the version that the person telling it is. There is, think to post-conflict countries that have had Truth and Reconciliation Commissions. The Sierra Leone Truth and Reconciliation report is more than, it's 1,000 pages long. It's the longest report I've ever seen in Sierra Leone. But the idea is to try and create as an accurate historical record as possible. But the Sierra Leone Truth and Reconciliation report is an interesting case in point. A huge amount of work was done in Sierra Leone to try and bring the groups together, and rightly so. There was also a lot of idea about reparation. If you really want to succeed in transitional justice, you do need to have this idea that you provide justice to victims, whoever they are, and accountability for perpetrators. You restore the rule of law and ensure that human rights violations are not repeated. And the ways you can do that are reforming institutions and obviously trying to promote sustainable peace. So in Sierra Leone, the Truth and Reconciliation Commission recommended that war victims, in inverted commas, receive compensation. In Sierra Leone, if you remember, after the war, there were very clear and obvious war victims. They were the war amputees. You might remember the story, and there are different versions of this, but the sort of overarching story is that to stop people voting at the election, people had their limbs removed, particularly their arms or their hands, so they couldn't vote for the opposition party. And this was a sort of a punishment. So there were a lot of amputee war victims in Sierra Leone. So in the mechanisms of the Truth and Reconciliation Commission, the idea was that they would receive compensation. That hasn't actually ever happened, I don't think, but the idea was they would receive compensation. But remember what I told you at the beginning about the indirect and direct health consequences. There was no polio campaign, no vaccination of polio campaigns for the entire duration of the conflict in Sierra Leone, more than 10 years. So there were a lot of people, a lot of children at that time, who contracted polio as a result of this. So to them, and understandably, they were also a war victim. They contracted polio because they didn't have access to a health camp. There was no vaccination. So they're war victims, but they are not recognised as such in the Truth and Reconciliation Commission report. So they're not going to get access to this mythological and as yet unfunded pot of money for war victims. But so you can see, what did that do? Well, it fostered discontent between the DPOs. So they started to have kind of infighting. So then to the outside world, to the international community, it looks like the DPOs are fighting amongst themselves as usual and again. So why should we bother funding any of them? They can't even manage to agree on one thing. Well, if you think about it, the conditions for those conflicts were already written in the Truth and Reconciliation report. So it wasn't necessarily something that was infighting amongst the communities per se. It was really something that happened as a result of what the international community and the Truth and Reconciliation Committee's report produced. So you can see that this really sort of makes the international community see that the DPOs become self-serving, and that then becomes problematic. So you can see how these transitional justice goals, whilst ideal are sometimes not necessarily the most ideal. There are other factors, and again, there are a lot of compounding factors about who the marginalised and excluded groups are. And the picture here is of all men. I think it's fairly clear that they're all men, they're usually men, and they are all former combatants. They were all members of the Sudanese People's Liberation Army. They were all combatants. Most of them are mine victims. And again, this is taken at an ICRC limb fitting centre. And what was really interesting was because actually these are a group in South Sudan. This was taken after the first peace agreement in 2000 and something like 6, 7, I can't remember when I was there. Subsequently, things have deteriorated in South Sudan. But the point was that these guys actually had quite a strong position in society. They were all former combatants. The SPLA became the SPLM, became the political party in power. They had good access to the humanitarian funding through the mine action, UN mine action. They were very, very prominent in the DPO community. So they had a very loud voice. So it meant that women with disabilities, children with disabilities, had far less prominence in the disability discussions in South Sudan at this point than any other, than these guys. So, you know, if we're talking about disabled people are all vulnerable and need protection, actually these guys weren't vulnerable and didn't really need protection. So, you know, it was a very good example of where we must be wary of not categorising all people with disabilities as the same group with the same issues, because actually they didn't have the same issues, and they weren't speaking about children or people with mental health conditions or children with learning difficulties. They were very much speaking for their own ends, and a lot of those ends were political, because they are a political group. So again, they were also covered by the protection mechanisms, because, and I'll come to this, the protection systems in the UN include mine victims. So again, it's this idea of paternalism, but I'll come back to that. So it's important in the humanitarian world anyway to know who the marginalised and excluded groups are, because that can also be a political exclusion. But it's very important to know in this context, in terms of people with disabilities, who are those that are not being engaged, who are those that are not being included. Obviously, if you think back to the slides I showed earlier, we also need to be aware of what the situation was before the disaster or conflict. What was the initial level of well-being like of populations? What was their level of self-protection? You know, Darfur was a good case in point about this. You know, the capacity of people in Darfur to be able to self-protect was weakened and eroded so much that it lost. What was people's livelihoods resilience like? What was their social capital? What support structures did they have? And very importantly, what legal mechanisms and protection frameworks were in place in that country? And this is obviously very important, because if you don't know what they are in the first place, how do you hold people account to those? So that can include legal frameworks as well as social protection mechanisms. I think social protection measures in most post-conflict countries are weak, but we'll come back to that. So I've already said to you at the beginning, I'm not a lawyer, but I think most of you, if you have any law background, you'll have some idea about the broad tenets of international humanitarian law. The laws of war, as they're commonly known, the 4 Geneva Conventions. Almost every state in the world has ratified them, and the additional protocols, which include Common Article 3, which is armed conflict within one country. That was important because traditionally it was seen as interventions had to be that the conflict had gone over the border between 2 or more countries, but that's not the case anymore. Importantly, the conventions are a protection mechanism, and they prohibit the use of certain weapons, so things like chemical, biological weapons, and military tactics, and they protect certain categories of people and goods, which obviously include health facilities and health workers, but also, in some instances, and I'm going to talk about this in a minute, it does tend to categorise people with disabilities as victims. So, as Janet Lord calls it, it's very paternalistic. But, and you have to put this in context, these were written a long time ago and aimed to protect civilians primarily in situations of war and conflict. So they are necessarily going to be the protection of those who are considered weak and vulnerable. And in the Convention, that does tend to mean persons with disabilities, particularly ex-combatants who have become injured. Before I go on, if you are interested in that, Janet Lord has written a very good, I don't know if any of you have seen this book, Disability, Human Rights and the Limits of Humanitarianism. It came out last year, and Janet Lord has a whole chapter in here about the Article 11, and particularly around this issue of the International Humanitarian Law and how it relates to Article 11. So I can only recommend that if you're interested in the legal side. It's very important to say that in addition to international humanitarian law, international human rights law is still effective in conflict. So it means Article 11, or the Convention on the Rights of Persons with Disabilities, still stands in any conflict. And both international human rights law and international humanitarian law are mutually reinforcing. However, they can also somehow, in some places, slightly contradict each other, and that's always been a challenge with human rights law. Another important factor is that some aspects of international human rights law can be suspended in a state of emergency, but the core ones, such as the right to life, cannot. So this is very important. So, for example, Sierra Leone has been in a state of emergency, for 6-9 months now? So it means it gives the government powers to override things ordinarily would be the case, to derogate certain rights of people, to give them more power. So again, that's a crucial point to remember in terms of vis-à-vis persons with disabilities. And again, even if states haven't ratified international law, some of it can become customary law. But that's a technical point that I'm not going to worry about. But it is important. And one of the discussions that Janet Lord talks about, and I'm not going to try and replicate it here because I'm not an international human rights lawyer, is this tension between, for example, prisoners with disabilities, prisoners of war who are prisoners with disabilities, and how what the Geneva Conventions say how they should be treated compared to what the Disability Convention says how they should be treated are often somehow different. So that can lead to some challenges and some contradictions. So, for example, in terms of things like mental capacity. So these are important issues. Another thing that I think is important to talk about is who is responsible. So these are the human rights conventions. As you know, the Convention on the Rights of Persons with Disabilities is broadly the responsibility of UN-DEFRA, but it's not exclusively the responsibility of UN-DEFRA. So who are the other agencies that are responsible for humanitarian conventions? The United Nations High Commissioner for Refugees is obviously mandated under the Geneva Conventions to be responsible for refugees. In particular, the principle of non-refoulement. Sorry for my appalling French, I feel like Rosemary there. And that means that you cannot be returned to your country of origin against your will. And if you remember, the Refugee Convention has a very set definition of who and what a refugee is. It doesn't include a person with disability, and that's an important point to remember. It's persecution against religious blah, 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 but it doesn't specifically state disability. Increasingly, UNHCR are taking on a protection role for internally displaced people. Again, this is a very important category differentiation. Internally displaced people, IDPs, have not crossed an international border, so legally are not refugees. They're, of course, citizens of their own country. So, again, it's a very specific legal definition. If you've crossed the border and successfully applied for refugee status, you become a refugee. UNICEF are, of course, responsible for the Convention on the Rights of the Child, so they're responsible for the rights of children. The UN Organisation for the Coordination of Humanitarian Affairs is a relatively recent body. The UN decided to try and put the humanitarian house in order in about 2005. So the OCHA, as they're called, are mandated to improve coordination amongst humanitarian actors, and I'm going to come back to that because it's a very important point. World Food Programme are pretty much mandated through the logistics to deliver food aid. And I've mentioned here the International Organisation of Migration. I think they're an interesting organisation. They're a bit like the International Committee of the Red Cross, Red Crescent, are an intra-governmental organisation. So are the IOM, and they support the work of UNHCR. As you can see, none of these agencies are, of course, disability specific, but all of them are increasingly including disability issues in their work as a result of the convention. It's the Human Rights Convention. But I think it's important to say that despite the work of the convention, a lot of the sort of evaluations of humanitarian responses, particularly the most recent ones in West Africa and Syria, are still noting that there is still significant exclusion of people with disabilities. Oftentimes, it doesn't necessarily mean an intentional exclusion. It just may be an unintentional, but I'll come back to that. But we know that there's still some significant gaps. I want to just show you this slide because I think it's important. When I said at the beginning the humanitarian system is cumbersome and complex, I think this diagram tries to give an idea of what should happen, how it should work. And there are 11 clusters. So as part of the reform of the United Nations humanitarian system, the humanitarian world was divided into 11 clusters. And these are sort of considered to be the key things that would need to be included in a humanitarian response. So things like camp coordination. Again, this is very important because if you think now about the sort of humanitarian emergencies we're dealing with in the world now, think about places like Syria. People aren't living in camps. They're mainly living in accommodation with other families. They're displaced into communities. But nevertheless, early recovery, education, telecoms, food security, health, logistics, nutrition, protection, shelter and water and sanitation. And if you see, I don't know how easy it is to read with this pale slide, but this is all sort of fitted into a sort of broad disasters, emergencies cycle, which starts, of course, the idea prevention is always better than cure, so prevention. We then get to mitigation. We then become prepared. Hopefully, or not, there is a disaster, ideally not. There's then a response, there's then a recovery phase, there's then a reconstruction phase, and then we start again. You start planning your prevention, your mitigation measures before the disaster happens. And this is all coordinated by someone called the Humanitarian and Emergency Relief Coordinator. It's very important. There is obviously no specific cluster on disability. That's obvious. As I said, theoretically, disability should be mainstreamed across all the clusters. In fact, it does tend to get included in the health cluster for reasons that are probably obvious. But increasingly, it's also included in the education cluster, blah, 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 and the protection cluster. Protection in this is the group's issue and issues identified as areas of specific concern in humanitarian emergencies. So traditionally, and they are listed as age, gender and diversity, so that would include disability, child protection, gender-based violence, housing, land and property, human rights and humanitarian action, internal displacement, mine action, protection mainstreaming, protection in natural disasters and protection of civilians. So what you see is this, it's trying to include under that, it's trying to bring together protection from the legal point of view, what the whole sort of humanitarian system is built on, the premises of the Geneva Conventions, and the much newer and much more nuanced work on human rights and protection. So it's really trying to bridge some of those gaps between protection under the Geneva Conventions, which is not very rights-based. It's very much to do with the kinds of conflicts that were happening then, and the human rights as a protection issue, which is much more recent. So when we're talking about any kind of humanitarian emergency now, this is the sort of the pattern of a response that the UN will follow. That's both at the international level and then in each country, each specific disaster, there is a cluster replicated at the country level. So more recently in Nepal, there will be a cluster system rolled out like this. So where does this finally, I'm now going to talk about Article 11. It's been taking me about an hour. For those of you that don't know, Article 11 says that states parties shall, in accordance with their obligations under international law, including international humanitarian law and international human rights law, all necessary measures to ensure the protection and safety of persons with disabilities in situations of risk, including situations of armed conflict, humanitarian emergencies, and the occurrence of natural disasters. So I wasn't there for the negotiation of this, and I want to say this was a pretty straightforward, but I know it wasn't, because you only have to mention the word conflict in the UN and it engenders a whole big fight between certain groups, and it did. For those of you that were there, you might remember this. It is necessarily a political. When you start talking about what states have to be responsible for vis-à-vis conflict, then states parties soon start to get a little bit upset about what their roles and responsibilities are going to be. So I think this is probably very carefully worded, and in a way it's a huge, broad, it's a broad area really. It covers armed conflict, humanitarian emergencies, natural disasters, with the different humanitarian responses that includes. But I think it really, there was a broad support from the committee about inclusion of persons with disabilities in humanitarian initiatives. And I think it was to try really to ensure that disability was included across the broader UN system, particularly across the humanitarian disaster system. And I think there has been, as a result of this, a lot of changes in the humanitarian system, and a lot of the UN agencies have repositioned their work to take into consideration. UNICEF have already developed a working group on children with disabilities in emergencies. Certainly the International Federation of the Red Cross, Red Crescent have developed a whole sort of federation-wide plan for disability inclusion across their work. So it has necessarily engendered a positive response. I'll come to the whole situation about the disaster risk reduction activities, but there was certainly a general Assembly resolution on humanitarian action. UNHCR have had what's called an executive committee conclusion on disability inclusion in their work. So it has really engendered a big response across the United Nations. Certainly the knock-on effect of that has been with the donor community, and I know the Australian government and the UK government both have had a strong impetus on disability inclusion, particularly in the humanitarian domain. And as Rosemary talked about yesterday, what a lot of these initiatives really have had in common is active participation of persons with disabilities. That it's trying to move away from seeing people with disabilities as a traditional vulnerable group in conflict and emergencies. This idea that people with disabilities are always there waiting to be helped. And I'll come to this. But the convention was built on this very active participation and who was marginalised and excluded. And as I've already said, the convention itself, including Article 11, does not specify any new rights. It just consolidates existing rights under international humanitarian law and international human rights law. And it's important to say they chose the words very carefully here, all necessary measures to ensure protection and safety. Protection was already a weak area in the humanitarian system. That was the given. So the idea was to try and strengthen this protection. So this really has been one of the areas where the whole human rights-based approach to humanitarian action, humanitarian responses, has been strengthened. Again, I think this isn't without challenges. If you speak to many humanitarian workers, they feel that it's enough of a struggle in many of the situations they're working in, and we can see this very clearly in places like Syria, to just deliver the basic needs for people to survive without trying to get into the whole issue of the human rights and the politics of how that aid is delivered. So a lot of the traditional humanitarian workers still struggle very much with this issue about human rights. They feel that whilst it's important, it's not going to be crucial for people's survival. But really that's sort of, I think, that most people now know on the ground, and Syria may well be a good case in point, that actually it's hard to separate the basic needs and basic human rights. Without them, without the two, people really can't survive. A lot of the humanitarian situations, and Syria again is a good case in point, if the rights weren't violated in the first place, we wouldn't necessarily be facing the humanitarian crisis that then subsequently happened. So it is in fact very difficult to separate the two. So it really is, the convention has been an area where they have tried to address this, bridging this humanitarian human rights gap. And an obvious point, if you think back to what we were talking about yesterday, the convention doesn't define disability, and that may be one of the challenges, but it does talk about disability as a resulting from the interaction between the environment and a person's capacity. Well, if you think about it, in a humanitarian crisis, whether that's a result of a volcano, an earthquake, or a conflict, that's certainly a challenge to a disjuncture between an environment and a person, whether that's their physical environment, the loss of support networks, the loss of livelihoods, and crucially, and perhaps one of the biggest killers, and certainly in the Ebola outbreak, this was one of the biggest gaps, the lack of information. If you don't know where to go to get help, if you don't know who to ask, if you don't know what you're meant to be able to entitle to, that can be a big killer for people. And of course, and very crucially, is this whole issue of political will and what states are willing to do and not to do. I'm not going to belabour this point, but I think we've talked about it already, but there are some fairly obvious links between disability and humanitarian emergencies. We know poorer environments and poor people are disproportionately affected by disasters and emergencies. And again, that's across the board. That doesn't just mean in low-income countries. The same was true in Hurricane Katrina. And I'm sure many of you who are from the States will remember the stories that were coming out post-Katrina about people with disabilities being excluded. People with disabilities are often very invisible in emergencies and subsequently sustain disproportionately higher rates of morbidity and mortality. Again, when I first started doing this work, that people would say to us, well, we don't see any people with disabilities, they're not... But if you're not seeing them, why aren't you asking where they are? You know, it doesn't mean they're not there. They're in their house. They're not coming to the registration tent because they can't get out of the tent. You know, so if people weren't asking where they were, well, that obviously led to an inability to access emergency aid. Humanitarian aid isn't necessarily delivered, and even despite all of the work that's been done, if you were watching the television after the earthquake in Nepal, you would have seen things being thrown out back of helicopters, off the back of trucks, time and time again. We know that that is an imperfect way to deliver. Of course we know that. Throwing stuff out the back of a helicopter isn't a very good way of delivering aid to anyone. Sometimes needs must, sometimes that's the only way, but we know it means that a lot of people cannot access that aid, so that's a given. Of course we know that humanitarian emergencies are likely to increase vulnerability to violence, as well as lack of access and lack of inclusion. And this can lead to sort of further complications, particularly for people with pre-existing disabilities. Another challenge is when we're talking about conflict and emergencies, we often think about people who sustain injuries or impairments as a result of conflict, landmine injuries, whatever. We forget that many people had pre-existing impairments. They are there, they are in the community, they were there already, and those impairments may in fact get worse. Think about people who don't have any access to medication. If you have epilepsy and you no longer have access to anti-epileptic medication, your condition may well deteriorate. So these things can get much worse. But it's really crucial, and sort of work has been done in this area. Certainly the Women's Refugee Commission back in about 2012 now, they did some work on refugees in camps, and they thought their estimates were that there were around 3.5 million refugees and internally displaced people living with disabilities in refugee camps and urban slums. Again, that number now may or may not be factually, it was a good estimate. But it is important to note that the WHO themselves think that armed conflict will be the 8th most common cause of disability worldwide by 2020, and in any affected population, so that's any type of conflict or emergency or disaster, 10% will go on to develop serious psychological trauma as a result of it, whether we call it post-traumatic stress or whatever. So these are massive issues. We're talking about a huge group of people that have been excluded. And I guess the other thing, some of the issues why people, I don't want to belabour the point. I think any of us, I could go around the room and we all know the barriers to people with disabilities being included. We know that there are social, cultural barriers, physical, attitudinal, and of course poverty. There are a number of other barriers too, and I want to think that some of these have changed over the years, but certainly I think within organisations there was a lack of awareness, and some of the organisations that had done some of the best work, and one big British NGO that I won't name, it's one of the most famous, there was a lack of memory about work that's been done. You know, we often say this, if you get one person who's like the disability champion and then the whole agency kind of becomes really disability aware, that person goes to another agency and then the work is kind of lost and we don't have this institutional memory about disability inclusion. So that's a real challenge, I think, to really sort of try and get a lot of work, momentum behind the work done. There's often a lack of referral between agencies, between sectors, and again it's this siloing. This was a very common problem in the humanitarian sector, and I want to say it's improved slightly, but I'm not sure that is the case. Previously I'd say there's been a lack of legislation and lobbying, but actually I think the disability movement and the international, particularly some of the disability and development NGOs, of which Leonard Tesher is one, have actually got behind this issue, and it's become quite a vocal and sort of well-campaigned issue. But there are still a number of challenges, and those particularly around data, and I'm going to come back to this, and cost. And this is always the shibboleth in disability issues, isn't it? What does all this cost? You know, I can't tell you if I had £1 for every time someone says to me, yes, but how much does it cost to include a child with disabilities in a school? Actually, it's very difficult to cost this. And again, it comes back to this issue of, do we need to count and do we need to make a cost evaluation? But certainly in the humanitarian sector, yes, you do, because someone's funding this, so it doesn't matter. I think there are a number of other issues that, certainly when I first started doing this work, we sort of noticed that there was a tendency in the humanitarian sector to assume that all people with disabilities, and we probably heard this from Rosemary yesterday, required some kind of specialist care. So let's say they were queuing for food or water, or in fact, shelter. People would still send them to Handicap International, which was doing rehabilitation, because of course you're a person with disability, you must have a health condition. Well, you still need food, you still need water, you still need shelter, you still need education. So this was a real issue and challenge. Linked to that was the idea that any kind of specialist care or adaptations are expensive. And remember, in the humanitarian sector, costs really count. A big issue has been that actually in many cases, and certainly in the post-conflict, post-disaster rebuilding, doing things in an accessible fashion from the beginning is much, much cheaper. Trying to retrofit it back to make it accessible is way more expensive. So it depends what type of adaptations you're doing. And again, it's linked to this issue of cost. A lot of agencies did tend to think that people with disabilities, as I said, this wasn't an intentional exclusion. So they assumed they were covered by the general aid distributions. Well, unless there are some specifically targeted measures, people with different types of impairment weren't necessarily included. If you're making announcements on radios or loudspeakers around a camp, people with hearing impairment don't know what you're saying. They don't understand. They don't get the message. So aid distributions don't necessarily include all different impairment groups. And then there were the sort of broad assumptions. There was this whole issue of people with disabilities can't help. They can't be included in the response. They can't be part of the community response because they can't help other people. Again, there are many, many anecdotal examples of exactly the opposite of that. And perhaps one of the most famous is the Twin Towers. When the Twin Towers bombing happened, 9/11 bombing happened in the US. Many of you might know this. There was a group of, I think it was a DPO of blind people on one of the floors. And they actually, partly as a result of people with visual impairment, are used to being in dark. They don't, they didn't panic. They could help with the rescue. They knew where to go to turn the emergency supplies off, the gas supplies. So actually they were very involved in the response and very, very, very helpful and much more helpful than many other people at that point. And then there's a whole assumption about people with disabilities just waiting around to be helped, the kind of typical sort of, charity model of people with disabilities, or that people with disabilities aren't able to work. Again, this is very important in the humanitarian sector because a lot of humanitarian aid, in an attempt to move away from the charity model, this idea that we have to help people affected by disasters, there's been a lot of work done about cash transfers, conditional cash transfers, cash for work. So it is sort of what it says on the tin. Cash for work schemes are basically, instead of this charity model, that you get people to do some work and you pay them. So then, well, that would kind of depend on people's capacities, age related, whatever. But some of this is just a matter of thinking a bit more laterally and how you can include people, but perhaps in different roles, in different levels of involvement. So it's not always the case that some of the structures in place are automatically excluding people with disabilities. I really want to say, as I say, I don't think any of this is necessarily intentional exclusion. It was just how the international community just didn't consider disability in quite the same way. And I think another factor was this whole issue around treating people as vulnerable. Traditionally in the humanitarian sector, and again, partly linked to limited resources, limited funding, it was really trying to do, the debate is always the greatest good for the greatest many, or the utilitarian debate, or whether you target a specific number of vulnerable or needy people. So a lot of work was done in the humanitarian about who are the vulnerable groups, and traditionally it was orphans, separated children, pregnant women, people with disabilities, older adults, and then it kind of got longer. I mean, the list was getting longer and longer and longer of who the vulnerable people are. So, it became sort of a bit of a redundant exercise in lots of ways. And as I said, it's much, much better to think about in that context who is marginalised and excluded. Another issue, and something we talked a lot about when we were doing the sphere revision, was this idea about compounding factors. You know, as Catalina said yesterday, you can be a woman with disability, you can be a child with disability, you can be a person with HIV and disability, an ex-combatant with disability, an IDP with disabilities. So which identity is going to come first? The woman, the IDP, the person with disability? You can be all of those identities at once. So it really is important to think about those sort of cross-sectionalities. And of course, another factor that we talk a lot about in the disaster risk world, but perhaps less so in the disability world, is this idea about resilience and building people's resilience and capacities. I want to just talk briefly about one example, because I think Syria, it probably is one of the sort of biggest humanitarian crises that we're facing, and I think it has been pretty slow onset in lots of words, and it's kind of happened without anyone really, I mean, there's been a lot of things about it, but how much interventions have been. Currently, we have the largest number of refugees in the world since the Rwandan crisis. We're about 6 million now. That's a phenomenal amount, so 6 million people from Syria. That's a significant number of people. We haven't seen this kind of level of displacement, as I say, in more than 20 years. It's a huge issue. And I think that one of the factors is that actually Syria, as I say, was a middle-income country. People had pretty good access to healthcare, to services, to protection mechanisms, to social protection. All of those things have been lost as a result of the conflict. So there has been a lot of work done to try and improve access for people with disabilities in the sort of Syrian response. But you have to put that in the context. You know, we're talking about a context where agencies are struggling. They're struggling because they don't have big donor funding to this disaster. They're already being squeezed in terms of the resources they have. The UK Disasters Emergency Committee did an evaluation of the Syria response from the UK Disaster Emergency Committee agencies, which are the 10 biggest agencies in the UK that have UK government funding. I should say that we also did some training some years ago now with the DEC on disability inclusion across the member agencies. So there was an awareness about disability inclusion from the DEC members. And the agencies in Syria, Handicap International and HelpAge International, established a system of disability and vulnerability focal points. Remember the cluster, the big group? So what they did was at reception centres, as people were displaced from Syria into Jordan, they were met by these disability and vulnerability focal points who did an assessment, and then they did outreach and home visits. So that was refugees with sort of some kind of specific need. That could be that they were older or they had some kind of disability. So of their survey, for example, in this survey, and it's 2013 survey, which is available, and I can give you the reference after. 30% of the refugees they interviewed had specific needs. 1 in 5 had a physical, sensory or intellectual impairment. 1 in 7, remember this idea about the chronic diseases, 1 in 7 had a chronic disease. 1 in 20 had an injury, which was almost 80% of them were a direct result of conflict. And older people accounted for 10% of the refugees with specific needs, made up 4 to 5% of those with very specific needs. So, I mean, the point of all of this really, and we can talk about this number, that there were large numbers of refugees that had specific needs and whether those needs were being addressed. The group made a number of recommendations around what should be done better by the agencies, in particular about collecting better data. But what I wanted to really talk about, again, remember back to the first point, the first slide, and thinking about these large numbers of people with disabilities in terms of refugees, that actually health status or disability status, impairment status, is not a determination of refugee status. So when people are being displaced, when people are going to to reception centres, in some instances, having a chronic health condition or having a disability can actually mitigate against your status claim. In some instances, it can go the other way. So it's not guaranteed which way, it's not either a positive or a negative. In some instances, it can be something that helps you get refugee status. In other instances, it's something that counts against your refugee status. So this is a very important fact. It's also important to say that actually, as I said 10 years ago almost when I started doing this work, we know that people with disabilities weren't really being included, and that oftentimes this was a result of inappropriate policies or neglect. But where have we really, how far have we come in this? And I think we've come some way, and I think there have been a lot of good examples, and there are many good examples, I'm going to give you some in a minute, of where we've done well. But I think there are still a number of gaps. And I think the biggest issue about where there are gaps is that there's little consensus about what is good practice. So of the good things that have been done and the good work that's been done, the very, very many guidelines, guidance notes, etc., there's not really consensus about what works. And that, if you think about the title of this session today, we're talking about disability inclusive development. I think this is one of the challenges. You know, how to evaluate what works in one situation may well not work in another. So it is really difficult. Linked to that, and I think it's something we touched upon yesterday, is this lack of agreement about standards and indicators. But actually, some of the things that when we're talking about a human rights-based approach, like participation, like inclusion, like empowerment, how do you measure those? They're pretty ephemeral. What does an empowerment index look like? What does an inclusion index look like? Does it mean sitting a child, we could talk about this endlessly, a child with disabilities in a class in an overcrowded, under-resourced classroom? Is that inclusion of a child with disabilities in a mainstream school, or is it just placing a child with disabilities in a mainstream school? So how do you measure these ephemeral things? They're quite difficult to measure. Secondly, linked to this is that we just don't have the data, full stop. We don't have the data more generally about persons with disabilities, and where we do have it, even in the higher income countries, as I say, it shows a differential between people with disabilities and non-disabled people. And I think this is also a fact. Having the data is one thing, it's the comparison data that we lack. That's really been one of the challenges. It's not just the data on people with disabilities. We need the comparison data, because that's where we're trying to show the differences, trying to show the gaps, for want of a better word. And I think, you know, from a humanitarian perspective, accurate data shouldn't be a prerequisite for planning programmes, but it is often one of the first things we get asked. And it's an article enshrined in the Convention. You might not know it's there, but I think it's about Article 34 or something, or I can't remember what number. There is a specific article in the Convention about improving data, so it's enshrined in the Convention. Of course, you know, policymakers, practitioners will say, without data, they haven't got a benchmark. Where are they starting from? You know, are we talking about 16% of a population or 6%? You know, what are we talking about? How do we know? Of course, from our perspective, it's making sure you ask the right questions in the first place. Otherwise, as with many other things in the humanitarian sector, it runs the risk of becoming a paper exercise. That actually, having a tick box on a questionnaire doesn't really affect meaningful change in the lives of people with disabilities. That's something that we can give them. So I think we really struggle to try and know how much data you need before you make your response. How much do you really need? And I think it's also really important to, we know we need to know who's the most at risk, and we know we can't do a one-size-all approach, because that doesn't work. We know it doesn't work. We know that we need to do comprehensive assessments, which include age, sex and disability disaggregated data, or as it horribly gets acronymed, SAD data. That really is sex, age, disability disaggregated, SAD data, which should be both quantitative and qualitative. Again, such data is more available in some contexts, for example, the European or the North American context, but, and it's a big but, in those contexts, you raise the issue of data protection and confidentiality. So actually, even if the data is available, can you access it? And is it right to collect that? Okay. I think also linked to this, and it's something we touched upon yesterday, and I think it's really worth highlighting this and coming back to it, is the issue of accountability. If you think about the context of the humanitarian sector, it's both the upward accountability to the donors, to the UN organisations, but also downward accountability to the affected communities. How are we making people accountable for the work they're doing? Donors also have a responsibility to make this a requirement of their funding calls, and I'll come back to this if I have time, about, you know, if we don't input disability inclusion as a requirement from the outset in the funding, then how can organisations be held accountable to it? But I think linked to that is the idea about recourse mechanisms, and it's something we don't talk about as much as we should. We talk a little bit about legal frameworks, but actually what recourse mechanisms do people have, and how can they be strengthened, whether that's complaining about agencies, complaining to the press, complaining to the police, what recourse mechanisms do people have? I'm going to skip over these two for the sake of time, but it's just to say that this is something that's been, acknowledged in work of people like DFID and the UN World We Want, which was leading up to the precursor to the Sustainable Development Goals. So it's not a new, a lot of work has been done around this. I told you I'd try to give you some good examples. There are many now standards and guidelines. There's been a lot of advocacy around this, legislation and policy change as a result of that, training around it, and a huge range of both humanitarian generally and then sector-specific guidelines, which include education sector, health sector, shelter sector. And actually, if you click on that link when you can access this, that is under the Global Protection Cluster. There's a range of resources on there that talk about some of these toolkits and guidelines, so I'm not going to go through them. I think there are a number of other achievements, and I think that it's certainly the case that we've had a lot of achievements as a result of the Convention. A lot of bilateral donor commitments, and I think DFID and DFAT are going to talk after, so they can explain a bit more about what they're doing. Certainly better and earlier mainstreaming of disability, improved rights-based language, and promotion of more integrated assessments. But, and there is a big but here, you knew there was going to be a but. For example, last year, many of you know that in the follow-up to the Hyogo Framework for Action, which was about disaster risk reduction and response, there was the Sendai Conference earlier this year, March this year, in Japan. And the Sendai Conference was really sent a very positive message. The Japanese government made a very public commitment to making the conference inclusive, which it was. And as you can see, some of you might have even been there. Huge representation of the Disability Caucus. Massive representation. It probably was the biggest lobbying group there, I think, in some respects. Great. A lot of commitments about disability inclusion, disaster risk reduction activities, that disability should be included with measurable indicators of progress, and of course they should include it link it to the Sustainable Development Goals. But one of the critics of the Sendai framework, and for those of you that are disaster risk reduction experts, one of the big criticisms more broadly of the Sendai framework is that it's a weaker, watered-down version of the Hyogo Framework for Action. So have, in fact, the disability movement just committed to being included in a weaker framework? And would we have been better to work across with other agencies and organisations to argue for a stronger framework in the first place? So this is a real challenge, that we've ended up being committed to something that is not as strong as the previous framework. I'm coming to the end now, before that goes off within the 3 minutes. But I want to just sort of sum up that there are a number of things that we sort of know. I think that we know there are a number of gaps in the humanitarian efforts, and those include, for example, specific at-risk groups, adults and children in residential care, in juvenile detention centres, in mental health, with mental health conditions, in prisons. In many of the countries affected by disasters and conflict, that's where people with disabilities are. We have to, and how do we ensure that we make, how do we get accurate information about people with disabilities in those conditions? We need to hear their families and get their voices heard. We also need to ensure that the data collected is used effectively, and that includes getting more and better research. I'm an academic, I have to say this. We need more and better research around disasters and the impact on people's lives. I think there are a number of positive examples, but I think that, that we still lack a set of meaningful indicators. How are we going to demonstrate this progress? I can tell you lots of anecdotes, but without meaningful indicators, we struggle to demonstrate that people with disabilities are being included and what their needs and capacities are in those inclusive responses. As I said, we need to ensure that active inclusion, what does it look like? We also need to ensure that funding mechanisms actually incentivise the humanitarian sector to include people with disabilities. That sounds bald and crass, but actually we know that there's a limited money. We need to make sure that everyone is included. Possibly one of the ways to do that is to really focus on what DFID horribly called the twin track approach, both mainstreaming disability across all the responses as well as specifically targeting people with disabilities. We also need to think about training packages that offer a set of skills and competencies. I could tell you a million different types of training, and I'm sure in every sector this is the case, but what are the sort of core competencies that we're talking about that would make us aware and ensure that people with disabilities are included? Is there a core set of competencies that people should have working in this sector? Certainly, and this is a given, DPOs, as I said from the beginning, had a lot of difficulty in the beginning with this thing like, being included in the humanitarian response. It's not a very inclusive society, the humanitarian sector. Certainly cluster meetings, cluster coordination meetings are the least accessible for many, many people, not just in terms of physical access. Local agencies often aren't invited to cluster meetings. So this has really been, to try and get DPOs involved and aware about what and how disability can be included across the humanitarian cycle, and really raising awareness about those issues, and really getting disability included on all the existing sort of frameworks, and that includes the post-disaster framework I'm ending now. I just want to end with a few of the ongoing challenges. I think there's still an issue around definitions of disability that we still probably could talk about endlessly. The coordination across and within sectors, the data I've talked about, the cost benefits, again, I think that's a huge gap for research. And there is this issue, and I'm going to throw it out here and not really have time to talk about it, but post-crisis, there's a lot of inequalities across different groups, whether it's youth, whether it's women, whether it's certain ethnic groups, a lot of inequalities. And post-conflict, there's a tension. So focusing on one group to the exclusion of others can just foster increasing anger. But there are a lot of opportunities, and I think we need to continue the momentum. I think there's a very significantly increased visibility post the convention. The Sustainable Development Goals are being much more inclusive of people with disabilities. The whole humanitarian mantra of build back better is a right for inclusion of inclusive development. The next year, it was mentioned yesterday, the World Humanitarian Summit. This will be a bun fight in Istanbul, but it is an opportunity to really ensure that people with disabilities have their voices heard. And of course, I have to say there's much more research in this area. Phew, I got to the end.